The skin makes up around 7% of total body weight, making it the largest organ in the body. Although it's hard to imagine it as a single organ. The skin, along with its accessory structures like oil and sweat glands, makes up the integumentary system. The integumentary system protects the body from infections, helps regulate body temperature, and contains nerve receptors that detect pain, sensation, and pressure. Now, the skin is divided into three layers: the epidermis, dermis, and hypodermis. The epidermis forms the thin outermost layer of skin. Underneath is the thicker dermis layer that contains the nerves and blood vessels. And finally, there's the hypodermis, which is made of fat and connective tissue that anchors the skin to the underlying muscle. The epidermis itself is made up of multiple layers of developing keratinocytes, which are flat, pancake-shaped cells that are named for the keratin protein that they're filled with. Keratin is a fibrous protein that allows keratinocytes to protect themselves from getting destroyed when you rub your hands through the sand at the beach. Keratinocytes also make and secrete glycolipids, glyco meaning part sugar and lipid meaning part fat. Glycolipids help to prevent water from easily seeping into and out of the body. Keratinocytes start their life at the lowest layer of the epidermis called the stratum basale, or basal layer, which is made of a single layer of stem cells that continually divide and produce new keratinocytes. These new keratinocytes then migrate upwards to form the other layers of the epidermis. The stratum basale also contains another group of cells, melanocytes, which secrete a protein pigment or coloring substance called melanin. Melanin is actually a broad term that constitutes several types of melanin found in people of differing skin color. These subtypes of melanin range in color from black to reddish yellow, and their relative quantity define a person's skin color. When keratinocytes are exposed to the sun, they send a chemical signal to the melanocytes, which stimulates the melanocytes into making more melanin. The melanocytes move the melanin into small sacs called melanosomes, and these get taken up by the newly formed keratinocytes. Melanin then acts as a natural sunscreen because its protein structure dissipates or scatters UVB light, which, if left unchecked, can damage the DNA in the skin cells and lead to skin cancer. Darker types of melanin and greater quantities of this kind of melanin are produced by individuals living close to the equator because they typically get more sun exposure. However, it's a fine balance because UVB light helps us generate vitamin D, which is an important regulator of calcium absorption. Keratinocytes contain cholesterol-derived molecules that are activated by UVB into vitamin D. As keratinocytes in the stratum basale mature and lose the ability to divide, they migrate into the next layer called the stratum spinosum, which is about 8 to 10 cell layers thick. Keratinocytes in the stratum spinosum layer have tiny proteins on the membrane that look like tiny spines. These help the cells adhere to one another. The stratum spinosum layer also has dendritic cells lurking around, and these are star-shaped immune cells that are constantly patrolling, looking for invading microbes. The next layer up is the stratum granulosum, which is 3 to 5 cell layers thick. Keratinocytes in this layer begin the process of keratinization, which is where the keratinocytes flatten out and die, and in this process they create the epidermal skin barrier. To do this, keratinocytes in the stratum granulosum layer produce large amounts of keratin precursor proteins and glycolipids which remain within granules called keratohyalin granules and lamellar granules respectively. Keratohyalin granules eventually start to aggregate and cross-link, forming enormous bundles of keratin within the keratinocyte. Lamellar granules, on the other hand, get secreted and stick to the outer cell surface. It forms a sort of cement between the cells, making them more resistant to external forces and water loss. Over time, the intracellular organelles disintegrate so the cells flatten out and die. Keratinization leads to development of the stratum lucidum layer, which is 2 to 3 cell layers thick of translucent dead keratinocytes that have secreted most of their lamellar granules. The stratum lucidum is only found in thick skin, like on the palms and soles of the feet, because those are the areas that need extra protection. The stratum lucidum is absent in thin skin, which covers the rest of the body, and the other layers are thinner. Finally, there's the stratum corneum, or the uppermost and thickest layer of the epidermis, which is like a wall of 20 to 30 layers, where the glycolipid acts like the cement and the dead keratinized cells are the bricks. The dead keratinocytes in this layer secrete natural antibiotics called defensins, which poke holes in bacteria. As new keratinocytes push up into the stratum corneum, older dead cells are shed, forming skin flakes or dandruff. Now, the dermis lies below the stratum basale of the epidermis, and it's much thicker than the epidermis. The dermis is divided into two layers, a thin papillary layer below the stratum basale and a deeper reticular layer. The papillary layer contains fibroblasts, which produce a connective tissue protein called collagen. The fibroblasts are arranged in finger-like projections called papillae, each of which contains blood vessels and nerve endings. One type of nerve ending found here is called a Meissner corpuscle. And this is a disc-shaped structure that detects fine touch, and it allows you to know exactly where, for example, a feather touches your arm. Another type of nerve found in the papillae are called free nerve endings, which are dendrites that detect pain. The papillary layer also contains macrophages, which capture pathogens that make it past the epidermis. It's also the papillary layer that's responsible for fingerprints. These are necessary for gripping and sensing abilities of the fingers and feet, and they make each of us as unique as snowflakes. Next is the reticular layer of the dermis, which is even thicker than the papillary layer. Like the papillary layer, however, the reticular layer contains fibroblasts with scattered macrophages. But the collagen in the reticular layer is packed very tightly together, making it an excellent tissue support. In addition, fibroblasts in the reticular layer secrete elastin, which is a stretchy protein that gives skin its flexibility. The reticular layer also contains the skin's accessory structures like oil and sweat glands, hair follicles, lymphatic vessels, and nerves, and all of the blood vessels that serve these tissues. One type of nerve ending found here is called a Pacinian corpuscle, and this is an onion-shaped structure that detects pressure or vibration, and it allows you to feel when someone's grabbing your arm. Since the reticular layer contains lots of blood vessels and sweat glands, it's also largely responsible for regulating temperature. When body temperature rises, like during a workout, the nervous system makes these blood vessels dilate and makes the sweat glands secrete sweat. Dilation of blood vessels brings more blood closer to the skin surface, and that allows heat to get lost to the outside environment. As sweat coats the skin surface, it takes heat to evaporate, so heat is slowly lost from the skin surface with every drop of sweat that evaporates away. In the opposite situation, when it's cold outside, blood vessels constrict, and that diverts blood flow away from the skin and there's no sweat, so body heat is conserved. Finally, there's the layer just below the dermis called the hypodermis or subcutaneous tissue. This layer contains fat cells called adipocytes, which help store most of the fat in our body, but also contains fibroblasts, macrophages, blood vessels, nerves, and lymphatics. The hypodermis helps insulate deeper tissues, provides padding to the body, and anchors the skin to the muscle with connective tissue proteins like collagen. Alright, as a quick recap. The skin, or the integumentary system, is the largest organ of the body that has many important functions in physiology. The integumentary system is divided into three major components, including the epidermis, dermis, and hypodermis. The epidermis is the most superficial layer, and it's responsible for protection from pathogens, the environment, and for vitamin D production. The dermis lies below the epidermis and controls temperature regulation, helps with sensation, and gives the skin its color. The hypodermis lies below the dermis and provides a point of attachment for the skin to the deeper muscles.
Hair, skin glands, including oil and sweat glands, and nails are all considered skin appendages, and they help with regulating body temperature and protection from the environment. These appendages are found in a layer of skin called the dermis, which is a layer sandwiched between two other layers, called the epidermis and the hypodermis. The epidermis is the thin outermost layer of skin, and the dermis is the thicker layer that lies below that. And the hypodermis is the lowest layer, that's made of fat and connective tissue and anchors the skin to the underlying muscle. Hair is found on nearly every part of skin, except the palms of the hands, soles of the feet, and the lips. Every strand of hair is composed of the shaft, root, and bulb that sits in a pouch-like structure called the hair follicle. The hair follicle is epidermal tissue that dips down into the dermis, and is associated with other structures like apocrine glands, sebaceous glands, the erector pili muscle, and nerve receptors. Inside the bulb lies the hair matrix, which serves as the active site of hair growth and gives hair its color. It contains two different cell types, follicular keratinocytes and melanocytes, and these cells receive blood from a small cluster of capillaries called the papilla. Similar to the epidermal keratinocytes in the skin, follicular keratinocytes in the hair replicate rapidly and die in a process called keratinization. During this process, keratinocytes produce keratin. Keratin is a long filamentous protein that comes in many different forms, depending on the type of keratinocytes producing it. But it's generally divided into soft and hard keratin, where soft keratin is produced by skin and hard keratin is produced by hair and nails. Hard keratin is much denser than the soft keratin produced by epidermal keratinocytes in the epidermis, and it gives hair and nails their durability. During keratinization, the hard keratin fills up the entire cell, causing the organelles to flatten out. Eventually, these follicular keratinocytes die, turning into compact little brick-like cells as they slowly get pushed further and further up into the hair follicle. As this process continues, different parts of the hair strand are made, including the hair root and the hair shaft that projects from the surface of the skin. Meanwhile, follicular keratinocytes at the bulb of the hair replicate only a set number of times. And once they've reached that maximum number, the hair follicle stops growing and falls out, which leads to baldness. Now, melanocytes produce melanin, which is a protein pigment, or coloring substance, that gives each strand of hair its color. Melanin is actually a broad term that constitutes several types of melanin found in people of differing skin color. These subtypes of melanin range in color from black to reddish yellow, and their relative quantity defines a person's skin color and hair color. Melanocytes move melanin into small sacs called melanosomes, and these get taken up by newly formed follicular keratinocytes, giving hair its color. Over time, these melanocytes stop producing melanin, which is why hair turns white as people age. Looking at some of the structures in the follicle, we can see nerve receptors that wrap around the hair bulb, and these get stimulated when the hair shaft is moved, like when a tiny bug walks over our forearm. There's also the erector pili muscle that pulls on the hair, making them stand up during cold weather or when you're frightened, creating what are called goosebumps. For a lot of mammals, this was an evolutionary trick to make an animal look larger than it really is to scare away predators. Sort of like when a cat gets scared and all of its hair stands up. Now, sebaceous glands, or oil glands, are located in the dermis layer of the skin, and they're found everywhere on the skin except on the palms, soles of the feet, and the lips. Sebaceous glands secrete an oily substance called sebum onto a nearby hair follicle or through pores that extend directly to the skin surface. As it turns out, erector pili muscles surround the sebaceous glands, so when these tiny muscles contract, sebum gets squeezed out. Sebum softens the hair shaft, which prevents it from getting brittle. Sebum also prevents moisture loss from the skin and is slightly acidic, which helps to deter pathogens. During puberty, there's an increase in androgen hormones that causes more sebum to be produced. Unfortunately, that excess sebum can block pores and plug up hair follicles, which creates tiny little enclosures that allow infections like acne and folliculitis to develop. And since there are more sebaceous glands in the face and scalp, those are the most commonly affected areas. Now, there are two main types of sweat glands. Eccrine glands are found everywhere except the lips, ear canal, clitoris, and glands of the penis. They're coil-shaped structures located in the dermis and have a duct that opens up into a pore on the skin's surface. Sweat is hypotonic relative to blood, and contains mostly water with small amounts of electrolytes like sodium and waste products like ammonia. Sweat also contains dermcidin, which is a secreted protein that helps destroy bacteria. But the main purpose of sweat is to help cool the body by taking the heat energy from the skin and helping it dissipate into the air by evaporating. The sympathetic nervous system activates sweat glands during heavy cardiovascular activity like when you're working out, or during the fight or flight response like when you run into a bear. And in those situations, sweating starts on the forehead and proceeds downward. Another trigger for sweating is fear or anxiety, like when you give a speech. But in those situations, sweating starts on the palms and soles. Apocrine glands are similar to eccrine glands, but they're bigger and fewer in number, and the secretions contain more lipids and proteins. Apocrine glands are located in the dermis layer in regions of the body like the armpit and the genitals. Bacteria love to dine on nutrients from the apocrine secretions, and that gives those body regions their distinct odor. Finally, there are also some modified apocrine glands that serve really unique roles, like ceruminous glands in the ear which produce earwax, and mammary glands in the breast which secrete milk. Finally, there are the nails, which grow from proximal to distal, or near to far on the tips of our fingers and toes. Now, looking at the nail from above, there are nail folds along each side of the nail, which is where the skin seals off the edges of the nail, as well as proximally by the eponychium. The eponychium is another nail fold that gives rise to the cuticle, which is the semicircular layer of dead skin keratinocytes that covers the junction where the nail enters the skin so that pathogens can't get in. Now let's look at a cross-section of the finger. There's the nail matrix, which can be seen as the lunule, which is the small, proximal white part of the nail at the near end. The nail matrix creates the nail plate, which is the hard part of the nail we can see as well as the free edge that hangs over the skin. The nail matrix is special epidermal tissue that dips down into the dermis, which contains nerves, lymphatics, and blood vessels that support the nail. Additionally, the nail matrix contains modified keratinocytes that replicate and undergo the process of keratinization, similar to what happens in the skin and hair. The youngest keratinocytes are in the nail matrix, and older cells die and keratinize, and become part of the nail plate. Alright, as a quick recap. The appendages of skin include hair, nails, as well as oil and sweat glands. The function of these accessory structures includes protection from microbes, temperature regulation, as well as heightened sensation and interaction with our environment. They serve as important gateways for multiple physiologic functions, and ultimately can tell a clinician a lot about somebody's health.
Albinism, meaning white, is a non-contagious, congenital condition that's defined by a drastic reduction or complete lack of pigmentation in the hair, skin, and eyes. The skin is divided into 3 layers: the epidermis, the dermis, and the hypodermis. The hypodermis is made of fat and connective tissue that anchors the skin to the underlying muscle. Just above is the dermis, which contains hair follicles, nerves, and blood vessels. And just above that is the outermost layer of the skin, the epidermis. The epidermis itself has multiple cell layers that are mostly keratinocytes, which are named for the keratin protein that they're filled with. Keratin is a strong fibrous protein that allows keratinocytes to protect themselves from getting destroyed when you rub your hands through the sand at the beach. Keratinocytes start their life at the deepest layer of the epidermis, called the stratum basale, or the basal layer, which is made of a single layer of small cuboidal to low columnar stem cells that continually divide and produce new keratinocytes that continue to mature as they migrate up through the epidermal layers. But the stratum basale also contains another group of cells, melanocytes, which secrete a protein pigment, or a coloring substance, called melanin. Melanin is actually a broad term that constitutes several types of melanin found in people of differing skin colors. These subtypes of melanin range in color from black to reddish yellow, and their relative quantity and rate at which they're metabolized define a person's skin color. When keratinocytes are exposed to the sun, they send a chemical signal to the melanocytes, which stimulates the melanocytes to produce melanin through a multi-step enzymatic reaction that begins with tyrosine. Once it's made, the melanocytes move the melanin into small sacs called melanosomes, and these get taken up by newly formed keratinocytes, which will later metabolize the melanin as they migrate into higher layers of the epidermis. Melanin then acts as a natural sunscreen because its protein structure dissipates, or scatters, UVB light, which, if left unchecked, can damage the DNA in the skin cells and lead to skin cancer. Melanin can also be found at the base of hair follicles to color hair, and in the eyes, including the iris, where it contributes to eye color, and the choroid tissue of the eye, where it helps prevent light reflection. Albinism is caused by a recessive gene mutation encoding any one of the enzymes needed to produce melanin. The resulting dysfunctional or deficient enzyme drastically decreases the amount of melanin that's made. Albinism can occur if there are mutations in proteins responsible for the transport of tyrosine, or melanosomes. It's linked to Shirayama-Higashi syndrome, which causes hypopigmentation, recurrent infections, mild coagulation defects, and varying neurological problems. Symptoms of albinism can be seen in the coloring of hair, irises, and skin. Coloring can range from drastically reduced pigmentation to white hair, milky white skin, and very light blue or translucent irises, which appear pink or red because of the retinal tissue lining the back of the eye. An absence of melanin in the eyes can lead to a variety of vision problems, ranging from focusing and depth perception to nystagmus and amblyopia, which is when there's misalignment of the eyes. In addition, albinism can cause freckles, moles, and lentigines, which are large freckle-like spots, to form on the skin, and it also increases the risk of skin cancers. Typically, diagnosis is initially made based on clinical observations, but a firmer diagnosis can be made with a skin biopsy or hair bulb extractions to test for the presence of melanin. Finally, genetic testing can give a definitive diagnosis. Treatment for albinism centers around preventing additional ailments that may occur from a lack of protection melanin normally provides. So, that means wearing tinted glasses to protect eyes or sunscreen to counter an increased risk of skin cancer. Some forms of albinism can be helped with medications that increase tyrosine levels, and others can be helped by low vision aids if eyesight is also affected. Alright, as a quick recap, albinism is a recessive genetic condition causing dysfunction in one or more enzymes involved in the multi-step production of melanin inside melanocytes. A decrease or absence of melanin can reduce or obliterate pigmentation of the skin, hair, and eyes, causing them to appear lighter in color or completely white. Definitive diagnosis can be made with genetic testing and skin biopsies or hair bulb extractions to test for the presence of melanin. Treatment generally includes supplementing the protection melanin would have provided to the eyes and skin.
Pemphigus vulgaris is a rare autoimmune skin disorder that causes blisters, or bulli, because there's separation of skin cells. Now, the skin is divided into 3 layers: the epidermis, dermis, and hypodermis. The epidermis forms the thin outermost layer of skin. Underneath is the thicker dermis layer, and finally there's the hypodermis that anchors the skin to the underlying muscle. The epidermis itself is made of multiple layers of developing keratinocytes, which are flat, pancake-shaped cells that are named for the keratin protein that they're filled with. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of stem cells, called basal cells, that continually divide and produce new keratinocytes. Below the epidermis is the basement membrane, which is a thin layer of delicate tissue containing collagen, laminins, and other proteins. Hemidesmosomes are a protein complex that attach basal cells to the basement membrane. As keratinocytes in the stratum basale mature and lose the ability to divide, they migrate into the next layer, called the stratum spinosum. The next layer up is the stratum granulosum, then the stratum lucidum, and finally the stratum corneum. The cells of the epidermis are bound together by protein complexes called desmosomes, most of which are in the stratum spinosum. Similarly to how the skin lines the outside of the body, the mucosa lines the inside of the body, and it's named for the surface it covers. So there's the oral mucosa, nasal mucosa, bronchial mucosa, gastric mucosa, intestinal mucosa, and so forth. Mucosa is made up of one or more layers of epithelial cells that sit on top of a layer of connective tissue called lamina propria. Just like with the skin, the mucosal cells are attached to each other by protein complexes called desmosomes, and the basal cells are attached to the basal membrane by protein complexes called hemidesmosomes. Pemphigus vulgaris is a type 2 hypersensitivity reaction, which is when the immune system produces antibodies that bind to the body's own cells. More specifically, immune cells, called B cells, produce IgG antibodies that can bind to specific desmosome proteins, desmoglein 1 and 3. It's unclear what triggers this to happen, but it's thought that it happens in genetically predisposed people and gets triggered by something like a herpes virus infection or a medication, like captopril or certain antibiotics. Now, all the layers of the epidermis are rich in desmoglein 1 and 3, while mucosal cells predominantly have desmoglein 3. So, in individuals with IgG antibodies that bind to both desmoglein 1 and 3, a person develops mucocutaneous pemphigus vulgaris because it affects both the skin and the mucosa. But in individuals with IgG antibodies that only bind to desmoglein 3, a person develops mucosal pemphigus vulgaris because the mucosa is affected. But the skin isn't really affected as there's enough desmoglein 1 to compensate for the loss. Now, when the IgG antibodies bind to desmogleins on the surface of cells, they trigger apoptosis, or programmed cell death. In that process, proteases get released, which are enzymes that break down the proteins that make up the desmosomes. The loss of desmosomes leads to acantholysis, which is the process of cells letting go of one another, and that directly leads to the formation of bulli, or blisters. Now, since hemidesmosomes aren't affected, basal cells remain anchored to the basement membrane, but separate from other cells of the epidermis, and that's called tombstoning. So, the bulli of pemphigus vulgaris are intraepidermal, meaning that they're within the epidermis, while the bulli of a similar disease, bullous pemphigoid, are subepidermal, meaning between the epidermis and dermis. Early on in pemphigus vulgaris, there can be bulli and ulcerations on the oral mucosa, but any type of mucosa can be affected. The oral lesions can be very painful and can lead to a person having difficulty with eating and drinking. The mucocutaneous form develops skin lesions as well. At first, the affected skin has flat red areas called macules, and they can appear almost anywhere on the body. Over time, the macules develop into bulli, or blisters, which eventually rupture and leave painful erosions. Sometimes the lesions can get infected, and that can worsen the pain and discomfort. A classic sign to help diagnose pemphigus vulgaris is the Nikolsky sign, which is when lateral pressure is applied to the lesion, and that causes a split to form between the upper and lower layers of the epidermis. In other skin conditions, like bullous pemphigoid, the skin doesn't split, resulting in a negative Nikolsky sign. In addition, a skin biopsy can be used to look for signs of acantholysis and tombstoning. Finally, direct immunofluorescence can be used. That's where antibodies marked with fluorescent molecules are used to tag the autoreactive IgG antibodies, which are attacking the epidermal cells. Treatment of pemphigus vulgaris can include both topical and systemic corticosteroids, depending on the severity of the disease. In addition, rituximab can be used. Rituximab is a monoclonal antibody which binds to B cells and inhibits the production of antidesmosomal IgG antibodies. Finally, to lessen the pain of the oral lesions, topical rinses like viscous lidocaine can be used. Alright, as a quick recap. Pemphigus vulgaris is an autoimmune skin disorder where B cells create IgG antibodies that target desmoglein 1 and 3. The destruction of these desmosome proteins leads to the formation of intraepidermal blisters in the mucosa and the skin. Symptoms include oral and skin lesions and flaccid blisters, which can be diagnosed by a positive Nikolsky's sign, skin biopsy, or direct immunofluorescence. Topical and systemic corticosteroids and rituximab can be used to treat the disease. Bullous pemphigoid is an autoimmune skin disease that causes the skin to form bulli, or blisters. Now, the skin is divided into 3 layers. The epidermis forms the thin outermost layer of the skin. Underneath is the thicker dermis layer, and finally, there's the hypodermis that anchors the skin to the underlying muscle. The epidermis itself is made of multiple layers of developing keratinocytes, which are flat, pancake-shaped cells that are named for the keratin protein that they're filled with. Keratinocytes start their life at the lowest layer of the epidermis, called the stratum basale, or basal layer, which is made of a single layer of stem cells, called basal cells, that continually divide and produce new keratinocytes. The stratum basale also contains another group of cells called melanocytes, which secrete melanin. Melanin is a pigment protein, or coloring substance. Below the epidermis is the basement membrane, which is a thin layer of delicate tissue containing collagen, laminins, and other proteins. Basal cells are attached to the basement membrane by hemidesmosomes, a protein complex that stems from the bottom of the basal cells. Just like how an anchor digs into the seafloor and holds a boat in place, hemidesmosomes dig into the basement membrane and hold basal cells in place. The exact cause of bullous pemphigoid is unclear, but it's thought that in a person with a genetic precondition, it can be triggered by medications like furosemide, captopril, penicillamine, nonsteroidal anti-inflammatory drugs, also called NSAIDs, and antibiotics. Bullous pemphigoid is a type 2 hypersensitivity reaction, which is when the immune system produces antibodies that bind to the body's own cells. Immune cells, called B cells, produce IgG antibodies, which are Y-shaped molecules with 2 regions: an antigen-binding fragment region, or Fab region, and a fragment crystallizable region, or FC region. The Fab region of the antibody binds to pathogens, which helps other immune cells destroy those pathogens. The antibodies can also activate a part of the immune system called the complement system, which destroys the pathogen, or induces inflammation. In bullous pemphigoid, the Fab region of IgG antibodies binds to proteins that make up the hemidesmosome. One of the proteins is called bullous pemphigoid antigen 1, or BPAG1, which is also called dystinin, and another protein is called bullous pemphigoid antigen 2, or BPAG2, which is also called BP180, or type 17 collagen. So lots of names for the same thing. The FC region activates the complement system. The process gets started when C1, the first of the complement proteins, binds to the FC region of the antibody. C1 then engages other members of the complement family, C2 through C9, some of which are activated by being cleaved or chopped by an enzyme. The cleaved fragments, C3A, C4A, and C5A, act as chemotactic factors, meaning they attract certain cells, in this case, the mast cells. The mast cells degranulate and release molecules like tumor necrosis factor alpha, leukotrienes, and cytokines. These molecules attract inflammatory cells like neutrophils, eosinophils, macrophages, and T cells. These inflammatory cells then secrete proteolytic enzymes, which destroy the proteins of hemidesmosomes, BPAG1 and BPAG2. So, if an anchor breaks and can no longer hold the boat in place, the boat floats away. So, when the hemidesmosomes are destroyed, the basal cells separate from the basement membrane and a split forms between the dermis and epidermis, resulting in what's called a subepidermal bullae. These subepidermal bullae are distinct from the epidermal bullae which form in the disease pemphigus vulgaris. In fact, in pemphigus vulgaris, the bullae form as a result from breaking connections between cells within the epidermis. Now, in bullous pemphigoid, the inflammation also affects the melanocytes, which produce more melanin that gets stuck within the cells of the dermis. Bullous pemphigoid is most commonly located on the lower abdomen, flexor side of the forearms, and anterior or inner thighs, but can also involve other areas as well. Unlike pemphigus vulgaris, it doesn't typically involve the oral mucosa. Early on, there's a red and itchy rash, and over time, it develops into large bullae, or blisters. The blisters typically evolve over a few days and leave behind crusted lesions that heal without scarring. A classic way to help distinguish bullous pemphigoid from other skin diseases, like pemphigus vulgaris, is the Nikolsky sign, which is when lateral pressure is applied to the lesion and it causes a split to form between the upper and lower layers of the epidermis. In bullous pemphigoid, the skin doesn't split. Pemphigus vulgaris will have the Nikolsky sign, but bullous pemphigoid won't. In addition, a skin biopsy can be done to look for evidence of antibodies and complement infiltration into the skin. Finally, the blood can be checked for autoantibodies against BPAG1 and BPAG2. Bullous pemphigoid is most commonly treated by stopping any medications that could be triggering it, and by using corticosteroids. Alright, as a quick recap. Bullous pemphigoid is an autoimmune skin disease mediated by type 2 hypersensitivity. Autoantibodies form against BPAG1 and BPAG2, and they allow blisters to form between the dermis and epidermis layers of the skin. Large, tense blisters on the lower abdomen, arms, and legs are the most common symptom. There is no Nikolsky sign, however, but there are circulating IgG antibodies, and this condition is usually treated with corticosteroids.